البرنسبلز بتاعت المشهدتي هي نفسها using the traction. هي المشكله كلها ان التراكشن تكنيك ده اغلب اللي ابتدوا يعملوه ابتدوا يقولوا ان الليت يوزنج يعني ليت فولو اب اوف ذيس كيسز كان اند وذ ريستينوزس. هي فكره التيشو اكسباندرز بتاعتنا في التجميل من زمان ان ده بتضعف الكواليتي. اولا عيوبها بتضعف الكواليتي اوف ذا سكين، فالتراكشن ده ممكن ينتهي بريستينوزس. هي فكره جميله طبعا يوزنج ذا.
هو حضرتك احنا عشان ما يحصلش ريستينوزس برضه بنعمل انستراكشن عيانه مجرد ما نشيل البالونه يحصل انتر كورس كل افري داي ويوزنج اورثو دايليتيشن.
احنا المشكله دي موجوده في كل حالات الفاجينا ريكونستراكشن، ان انت لازم العيانه لو متجوزه يبقى في انتركورس كل يوم، لو مش متجوزه يبقى في ريجولار دايليتيشن اند ذيس ميجور بروبلم. لكن انا سعيد جدا نعرف ان في موديفيكيشن موجود. الترانسكس بقى ما ينفع لهمش الكلام ده ليه؟ ما عندكش باوتش. شوف كل انواع التراكشن سيرجري على الفاجينا ديمبل كده او نوتش صغيره تحط فيها الحته بتاعتك، سواء كانت بالون او اكريليك اوليف زي ما الامريكان بيعملوا. لكن في الترانسكس ما تنفعش خالص لان ما عندكش حاجه. في الترانسكس I think you get different story, you have to get reconstruction from zero. وعلى فكره مش كل الحالات فيها this pouch، واختيار في التراكشن سيرجري الباوتش الصح هو اختيار مهم جدا، لانك لو حطيتها على اتريتيك فاجينا
ممكن تعمل فولس مسج،
مش هتنفع خالص وممكن تعمل لك مشاكل.
ثانك يو بروفيسور ماكين. انا عارف انت لازم تمشي عشان سيد رئيس الوزراء. اتفضل. ثانك يو فيري ماتش. It's my pleasure to present Dr. Ralph Jo Khadar, and I just knew from Dr. Ralph that his ancestors are from Halab, Syria. So it's quite interesting to have you. He's going to talk about laparoscopic sacropexy for the management of prolapse. Can we preserve the uterus? Dr. Ralph.
Dear board members, dear colleagues, I'm happy to have my second lecture here today. And I was asked to talk about laparoscopic sacropexy for the management of prolapse and about the issue of hysterosacropexy, that means the uterine preserving kind of this operation. And this would lead us to my question, why is this issue important nowadays? I will go through these topics with you, and it's hard to give a better lecture than Professor Makin did, but I'll try my best to give you something interesting too. And I'll start with facts and fictions about preserving uterine preserving gynecological surgery. I'll start with fiction because fiction is sometimes more amusing. And if you look into the magazines and newspapers in Europe, you will have a lot of topics presented there. But if you look closely, you will often find some topic dealing with the issue that too many women have lost their uterus or have had hysterectomies performed on. And I just made a small research and found out that more than 50 non-medical magazines, clips, programs, and interviews had dealt with this issue in 2013. And of course, the patients are eager to Google about that, and they come to us when we consult them for the operations, and they're eager to ask about preserving the uterus. So what are the facts about this matter? And these are data from the Robert Koch Institute in Germany, which is the epidemiological center, and it states that from 2000 till now, 1 out of 6 women aged 18 to 80 years has a history of a previous hysterectomy. And actually, almost half of these women have had the hysterectomy performed between the ages 40 and 49. So in Germany, the prevalence of performing a hysterectomy lays with 17.5%, rather in the middle range. When we look at other countries, the Scandinavian countries have a range of 11%, and the British literature shows a prevalence of 20%, whereas the Americans are the leaders in this segment, performing more than 30% of women a hysterectomy. What has changed in Europe, especially in Germany, in the last years is shown in this table. This is the statistic from the year 2000 until 2011, and we see a decline in the number of hysterectomies performed. And when we look at the specific indication for hysterectomy, the hysterectomy performed for uterine fibroids has decreased of about 40%, and performing a hysterectomy for dysfunctional uterine bleeding has decreased at about 60%. That's because we perform uterine preserving surgeries instead, mainly laparoscopically for the uterine fibroids. The only issue that hasn't changed much is performing a hysterectomy for pelvic organ prolapse. Also, we perform more operations for pelvic organ prolapse. The rate of hysterectomies remains the same. That's why this issue is so important nowadays. And is there a need to remove the uterus whenever we perform an operation for pelvic organ prolapse? I'll have you with me looking at the German guidelines for a moment. And it states, I translated it, abdominal sacropexy is the gold standard regarding prolapse surgery for apical defects with an evidence level of 1A. Still, the laparoscopic sacropexy seems to achieve the similar anatomical success rates, but we still have less data upon that. That's why it has an evidence level of 2B in the German guidelines. What do the guidelines say to uterine preserving pelvic organ prolapse surgery? Long-term data still are missing. That's why the evidence level is only 2A. But we can give our patients the option of uterine preserving surgery, since all data available seem to be very favorable for this kind of surgery. Let's go through the available data. This is a rather recent review from Christopher Maher from Australia, published in the International Urogynecology Journal in 2013, and it states that consistent level 2 and 3 evidence suggest that sacral hysteropexy is as effective as sacral colpopexy performed along with hysterectomy regarding the anatomical outcome. So it seems to be as beneficial for the anatomical outcome as the cases of removing the uterus. One great difference is that performing a hysterectomy was associated with a 4-time increase of mesh erosions compared with sacral colpopexy without the hysterectomy, and it is an evidence level B, so rather good evidence level. Long-term follow-up is only available for 4 years, also published in the International Journal of Urogynecology. In this case, colleagues from Britain had 180 women consecutively operated in this manner, and we had only 4% re-prolapse of the apex. That means we have a success rate of 96%, which is consistent with the literature we have for colposacropexy with uterine removal. One very important difference is the rate of mesh erosions, which is very, very much lower in this case, and our colleagues in this study had no mesh erosions in these 180 patients. Regarding patient global impression, which means how happy the patients were with the operation, the greatest proportion you see was very much happy and feeling very much better after the operation, and 23% feeling better. Together, they consist 90% of patients. So 90% of patients were very happy with the operation and felt either much better or very much better, and only 13% felt a little bit better and 1% felt no change. This is the POP-Q score. For those who are not familiar with the urogynecology, this score is measured at 6 points of the vagina for better description of the kind of prolapse in all the 3 compartments, the anterior, the middle, and the posterior compartment. And what's a very important figure is the green marked figure of -6. This measures how much the cervix, point C, is elevated in the vagina after performing this kind of operation, and the medium was -6 centimeters, and the range went from -4 to -12. That means you can elevate the descending cervix for -4 to -12 centimeters and the medium -6. So as much as you would need to correct the anatomical failure properly. This work with 2 months follow-up showed that laparoscopic hysterectomy added about 35 minutes operation time, added a blood loss to the operation, added something to the surgical risk, but wasn't correlated with a better outcome. So all the data showing no better outcome performing hysterectomy. What is left to say is that one specific complication which is seen mainly with uterine preserving prolapse surgery is the risk of cervical elongation after the surgery, which occurs mainly many years afterward, more than 5 years afterward. And this data presented here, it's shown that about 10 to 15% of the patient had this cervical elongation after the operation. And this is an MRI of one of these patients, and the cervix is elongated to about 6.5 centimeters. And we went anatomically to study why this happened, and there's very scarce literature, very few literature about that, but it seems that the deepest point to attach the mesh on should be at the level of the attachment of the sacrouterine, of the uterosacral ligaments to the posterior cervix. If you fail to stabilize this part, you will elevate the whole uterus and still have a descent of the last 1 centimeter, which will cause the cervical elongation. And that's what you have to take in regard with this technique. So this is our protocol at the University in Hamburg. What do I do when counseling my patients? I select the patients in following manner. Young patients with the wish for later conception are always offered a uterine preserving pelvic organ prolapse operation. Young patients with a wish for mesh-dependent repair, not the classical non-mesh operations, are offered the hysterosacropexy 2. And any patient who wishes to preserve the uterus can be offered this kind of operation if following additional aspects are also kept in mind. You have to have a pap smear no older than 6 months with the result of pap 1 or 2, and no prior history of cervical dysplasia. Unless you do that, you might get in interference with medical legal issues later. You should have a normal-sized uterus with no uterine pathology. Mainly, you shouldn't have big fibroids when you preserve the uterus. This may have some influence on the later outcome. As for that, I'm done with the data. I wanted to tell you that we perform about 15 workshops a year at the University of Hamburg for laparoscopic gynecology. We have almost 100 colleagues from Germany visiting us, and all the procedures we have we present in an almost live surgery session, and I've cut one of these surgery sessions short just to show you how the hysterosacropexy as operation is performed. I thought it would be better to choose a thin patient to show you that, because you wouldn't see much if I choose a obese one. This is the look in the pelvis of a rather young patient having a uterine descent grade 2 to 3. And we start with a 0 grade optic, with a straight optic laparoscopy, no angle optic needed in this case. And we start with preparation of the promontory. We just cut the peritoneum covering the promontory, and we allow aerodissection. That means through the pressure inside the abdomen, the peritoneum is elevated from the subperitoneal fat, and this technique I presented at the European Society for Endoscopic Surgery. It is a bloodless technique. We don't need suction devices. The blood loss is under 10 milliliters through the whole operation. You have to keep in the right anatomical layers, and you see in this case I am preparing the inferior hypogastric plexus, and it should be, you should always take care not to injure the inferior or superior hypogastric plexus. Unless you do that, you will cause some functional problems, mainly in urinary and bowel function. And we go rather a little bit right to the midline and create this tunnel beneath the peritoneum for later placement of the mesh. In the next step, we look at the uterine cervix. At this area, preparation of the peritoneum from the posterior wall of the cervix is rather hard because you don't have this subperitoneal tissue. In some cases, you will need to use electric bipolar devices if small bleeding is encountered. And we carry on the preparation till the level where the uterosacral ligaments meet at the posterior wall of the cervix. And this is to show, I chose this patient because it's very obvious to see the inferior hypogastric plexus going down there subperitoneally. And what we try to do is to see the anterior surface of the sacrum at the promontory level, and this is the longitudinal anterior ligament, which is a very firm ligament. Even in patients having very bad connective tissue, this is still a very firm tissue to place the mesh on. And this is the medial sacral vein, which should be preserved. If you cut it through or cauterize it, you may cause a peritonitis later after the operation. The ureter, the right ureter, is shown here. You should always keep in mind that it's passing the promontory at this level. Right now we have created the subperitoneal tunnel till the lower edge of the cervix, and now we should place the mesh. And as you see, the deepest part of mesh placement takes place at the level where both uterosacral ligaments meet at the posterior wall of the cervix. Some surgeons try to avoid this region because if you go only half a centimeter deeper, you will go through the posterior vaginal wall and you may close the posterior fornix and cause an infection later because the mesh shouldn't be there. As for now, placing this mesh at the posterior wall of the cervix and the isthmus of the uterus is performed, and you can either use Titan clips like we're doing here, or you can suture the mesh at the level of the promontory. You should always keep in mind you should perform a placement of the mesh which is not under due tension, because this patient should later be able to perform sexual intercourse. And in this case, I will show you that we will keep like 1.5 centimeter mobility of the cervix. Now my assistant will leave the manipulator, go down, and the uterus descends and descends, and after 1.5 centimeter the mesh is stretched and the descent is stopped at this point. Still, you can push the uterus inside. It's very mobile, so it won't have any harm for sexual intercourse for the patient. These meshes are made of polypropylene, so they may cause adhesions to the bowel. That's why the care should be taken to reperitonealize the complete area and cover the whole mesh. And this step should be taken with the same care as the other steps in the operation. This is how it looks like at the end of the operation. We had a blood loss of less than 20 milliliters. We didn't use the suction device. It's very harmless. The operation time is about 45 to 50 minutes, and the patient was very happy after the operation. Okay. Thank you for your attention.
Thank you, Dr. Ralph, for this nice presentation. We have 2 questions for Dr. Ralph. Dr. Hisham. عايزين مايكروفون لو سمحت.
Okay, I will first repeat the question of the colleague. He's asking if it is routine to perform an anterior colporaphy for repair of a cystocele additionally to this procedure. Well, actually, a lot of presumed cystoceles might not be any. And there are new publications from France now that the apical descent will cause a false cystocele which isn't there. So you should rule out a cystocele using a pelvic floor ultrasound. in about 60% of cases, after stabilizing the apical compartment, you won't have any left cystocele to see with vaginal examination. But in case you have a pelvic floor examination, ultrasound of pelvic floor, and you see the cystocele, yes, in that case we do an anterior colporaphy and we do it simultaneously. You can do it either in this or the other way. I think it's more time consuming to do it after the sacropexy because it's not so easy to reach the upper part, so I do it before. But literature doesn't say that it's better. It's my way to do it. You can do it either ways.
Any question?
You really find
Sure.
laparoscopic procedure to be much superior than the vaginal repair?
I don't think that laparoscopy is superior to vaginal repair. No, not at all. But we have the issue of the FDA warning that came out in 2008 and 2011 from vaginal meshes. And when using a mesh, yes, I think for mesh-dependent surgery, the laparoscopy is better than the vaginal route. But generally, it's not. If you do a non-mesh repair, I think the vaginal route is superior than the laparoscopic route. Laparoscopic surgery for prolapse can only be performed using a mesh. So if you do a non-mesh repair, you should take the vaginal route.
Thank you, Professor.
Thank you.
Okay, my question, please. My name is Hisham Haggag. You said that the uterus should be free of any pathology, especially fibroids.
Yes.
Is there a cutoff limit for the size of the fibroid? Because many patients at this age group would have asymptomatic fibroids. This is my first question. And my second question, did anyone describe this procedure that you have just explained to be done bilaterally, or is it just done unilaterally?
Okay, thank you for your question. The cutoff for the size of fibroids isn't given in that way. There are some papers dealing with the volume of the uterus. But measuring the volume of the uterus is not so easy. You need special software programs to do it very precisely. Still, if you have big fibroids, then you can presume that you have a big uterine volume, and I wouldn't perform the operation in that case. Having small fibroids, I don't see any problem with that. Some other issue, if you have a 50-year-old patient, then you won't expect the fibroids to grow too fast. In that case, I wouldn't have many problems performing this operation. If she's younger and I'm afraid that these fibroids will grow fast, then I might think of removing the uterus. In that case, I would do it supracervical and leave the cervix to perform the attachment of the mesh on the cervix. For the second part of your question, going left side in the pelvis for bilateral fixation is hampered a little bit because of the localization, anatomical localization of the rectosigmoid. So it's hard to get there in regards of the technique. But if you manage to do a bilateral fixation, then you have a better outcome regarding the functions of the bladder. And we have a series of that. We have a special operation of bilateral sacropexy, and we've published that, but it's still under only performed at our university. For the ethical committee hasn't given it free yet, but I think we'll have enough patients in 1 or 2 years to talk in a bigger, in a louder manner about that procedure. Yes, please.
First of all, my name is Sharif Hamza. Thank you for coming to our country. I'd like to ask you about the Douglas pouch sacropexy through the Douglas pouch. Do you have any experience versus laparoscopic surgery?
Excuse me again, please.
Through the Douglas pouch, through the Douglas pouch,
Yes.
vaginal sacropexy.
Vaginal sacropexy. There are some colleagues performing that, and there are some data about that, and they're good data. What I'm sometimes afraid of is the risk of infection if you open the pouch of Douglas and complete the operation laparoscopically, but the papers who are available don't show this higher risk of infection. Still, I think if you're a skilled laparoscoper, you can perform it totally laparoscopically. It's time-saving, and it's with less blood loss, and you've got excellent outcome. But I'm sure some colleagues would rather perform it with a combined vaginal laparoscopic approach, and it's a good approach too. Thank you.
pleasure to introduce to you Professor Hisham Badawi, Professor of OBGYN in Cairo University. He will be talking to you about the chronic inversion of the uterus.
Actually, I have a video of surgical management for a case of chronic inversion of the uterus. Uterine inversion refers to the descent of the uterine fundus to or through the cervix, so that the uterus is turned inside out. Non-peripheral uterine inversion has been described as a rare occurrence by several authors, but how rare it is has not been estimated. However, the fact that many gynecologists might spend their entire practice without encountering a case of chronic inversion gives us a clue of its infrequent nature. The reported incidence of complete uterine inversion in postpartum patients varies between 1 per 2,000 to 30,000 deliveries. Mismanagement of the third stage of labor may be the most common cause of peripheral type, while large submucous myoma is the commonest cause of the non-peripheral type. The anatomical classification is described in 3 stages. Stage 1, the inverted fundus extended to but not through the cervix. Stage 2, the fundus extended through the cervix but not through the vagina. Stage 3, the inverted fundus extends outside the vagina. And this is a diagram showing the different levels of chronic inversion of the uterus. Treatment depends on the preoperative diagnosis, but hysterectomy is recommended for benign causes if childbearing has been completed. However, when the inversion is associated with malignancy, radical hysterectomy is indicated. The following is a case report of a woman who presented with non-peripheral uterine inversion secondary to uterine fibroid at our casualty. Case report: a 50 years grand multiparous patient presented to our casualty department complaining of lower abdominal pains and severe attack of vaginal bleeding. These symptoms started 2 days with the start of her menses. The symptom aggravated on the day of her consultation, and she was known to have uterine fibroid for 4 years. On general examination, the patient was pale and tachycardic. On abdominal examination, there was marked tenderness. Local examination showed vaginal bleeding, tenderness, and a globular solid mass filling the vagina. On transabdominal ultrasound, the uterus showed cupping of the fundus with the 2 ovaries seen inside the concavity of the fundus. Uterine inversion was suspected. Laboratory investigation showed marked anemia, otherwise investigations were normal.